Professor Mark Howard is at the Institute for Breathing and Sleep in Victoria. He has completed his PhD at the University of Melbourne and is currently a board member for the Institute of Breathing and Sleep. Now, Mark has overseen the development of an ambulatory model for implementing ventilation, community housing for ventilator-dependent patients, and a diaphragm pacing service in conjunction with Victorian Spinal Cord Services, so very high credentials. He's also currently looking at different models of ventilation, assessing the utility of nocturnal monitoring for the implementation of ventilation and evaluation of assisted cough techniques, and I guess that makes him a fantastic person to tell us a little bit more about how we can help people with MND benefit from non-ventilation. So thank you very much.
So I was very pleased when I got off the plane from Melbourne this morning. I was able to ditch my tie and jacket when the temperature went up by about 15 degrees. I was tempted to come in shorts and thongs just to push the point further, but I'll let that be. The work I'm going to present really, I just need to acknowledge in advance a huge team effort, both from our own group at Austin Health Institute for Breathing and Sleep. Nicole Shears is in the audience. She's a good way through her PhD and she presented some of her work yesterday. We work very closely with Calvary Healthcare Bethlehem with Susan Mathers and Paul Torman, and also very gratefully supported on a number of our projects through the Motor Neurone Disease Research Association. So, right, I'm onto this one. I call this my respiratory physician's neuroanatomy slide, or neuroanatomy for dummies, if you like. There's several aspects of the respiratory system that are impacted by motor neurone disease. And we think, of course, of the diaphragm, certainly critical for breathing, contributes to about 2/3 of our breathing capacity. But we shouldn't forget about the chest wall muscles that are also impacted by motor neurone disease. And they need to be linked to other parts of the system. So the upper airway also is important. In fact, when you take a breath, the first thing that happens is the muscles in the upper airway are activated to keep the upper airway open. So when that's impacted in motor neurone disease, that can be a contributing factor to why you have breathing difficulty as well. And then with breathing out, while that's normally a passive thing, when we cough, we use our abdominal muscles to cough and clear mucus and secretions, and that's a key component of Nicole's work. So one of the key things that occurs then when these muscles become weaker, and particularly the diaphragm, you become short of breath, but in particular become short of breath when you're lying flat. And when you breathe in, if the diaphragm is particularly weak, you'll see indrawing of the abdomen as the negative pressure in the chest sucks in the abdomen. And so lying flat and becoming short of breath when you're lying flat is one of the key things that can occur. Stephen Burke's done some fantastic work in this area, and in earlier work looking at the sorts of things that people presented with describe some of these symptoms. So orthopnea, or difficulty breathing lying flat, was one of the things that people noticed most and were keen to get assistance with, and respiratory support can certainly help with that. Becoming short of breath just during other activities, initially physical activities, but it can be being short of breath at work, at rest, also occurs in a proportion of people. And then there are symptoms that are related to the impact that can occur on sleep when there's breathing difficulty overnight. And so sleep can become disrupted, resulting in sleepiness during the day, contributing to headaches. There can be some build-up of carbon dioxide in some people, which also can contribute to headaches. And we see a reduction in lung capacity occur. And so when we're monitoring people with breathing difficulty, we tend to monitor not just the symptoms, but a range of lung capacity measures and measures of breathing muscle strength, to help gauge whether people are likely to have difficulty with their breathing as a key problem during the course of their condition, and also the timing of when to try and assist them if they choose some of the tools that we have. So one of the key elements of things that we use, non-invasive ventilation, we provide a service across Victoria. We have about 1,000 people across Victoria on non-invasive ventilation. About half of those people have some form of nerve and muscle condition, from spinal cord injury to muscular dystrophy, and certainly people with motor neurone disease. And so that involves a mask, usually over the nose, or it can be nose and mouth, often initially worn at night time, linked up to a small ventilator. And every time you take a breath, you get an increase of pressure through that ventilator that provides a bigger breath compared to what it would be if you were not on it. But there are other things you can fine-tune on the ventilator to try and make sure it coordinates well with the person. What if the person is trying to breathe here but the ventilator breathes there? It's not well coordinated, then it's not going to be very effective and it's not going to be comfortable to use. So we spend a lot of time working with people to try and make sure that the way that the equipment is set up and functions works well for that person. This is a bad picture of somebody sleeping overnight with motor neurone disease. This would be a picture across the whole night, and these are different bits of sleep. So every time you see a bar here, you're awake. So there's just little bits of sleep, and it's early stages of sleep predominantly, very disrupted. Down here, if you look at oxygen level, every time they try and go off to sleep, the oxygen level is falling down, okay? Again, over here. And carbon dioxide level builds up as soon as they go off to sleep, and the drive to sleep drops off, and some of the input to the muscles in the throat and the breathing muscles also drops off. So lousy sleep quality. This is on non-invasive ventilation, the same person, and what you're seeing now are these blocks of sleep, and here's some really long, deep sleep, periods of REM or dream sleep, and the oxygen levels remain normal through the night. So set up well, it can be a very effective tool at managing and supporting breathing, particularly during sleep, but also during the day. So this is a publication from David Bernowitz from our group from about 10 years ago, looking at changes in some of those sleep overnight parameters on ventilation. So reduced disruption or arousals from sleep, improvements in efficiency of sleep, the amount of sleep time, and on the last one, improvements in oxygen level overnight. So certainly when you look from day 1 to day 2 on a breathing support, it improves those things. There's been a number of publications, and this is the first and important trial from Burke, where they did a randomised controlled trial of non-invasive ventilation to look at impacts on quality of life and survival in motor neurone disease. This was his initial work showing that when you started ventilation, you had improvement in overall quality of life. This is improvement in a measure of sleep-related quality, also improving, although at that time there was still fall in the ALS functional rating scale, which Mary Louise mentioned before. So these aspects improved, but you still had a decline in the functional rating scale. And then moving into his randomised controlled trial, this is a difference between the non-invasive ventilation and control groups, looking at how well their quality of life was sustained. And so the NIV group had quality of life sustained for a longer period compared to those who were not on it. In his trial, though, there was a strong suggestion that that improvement predominantly occurred in people who did not have significant bulbar symptoms, so where their upper airway was functioning reasonably well. And so this is those who had bulbar symptoms, and there wasn't much difference, and then those without bulbar symptoms. Some of our recent work, which I'm going to show you, challenges that, and there might be some particular reasons why that was shown in this trial. This is the survival, the same measure that Mary Louise showed before. So blue is with non-invasive ventilation, showing overall improved survival, but again suggesting that that was in those only who had no significant bulbar involvement. So we've been looking in recent years in our cohort, the study as a controlled trial was in a relatively small number of people, but we've been able to look in a cohort in Victoria of about 1,000 people over a prolonged period of time and try and assess whether those results stack up. Does it improve survival and quality of life, and are there differences for different people? So firstly, to comment that those who received non-invasive ventilation, this is not a randomised trial, it's retrospective data, that there were differences in a number of things, including age and gender, use of riluzole, and also gastrostomy feeding. So we had to adjust the analyses for all of those measures. And this is the overall difference in survival. So non-invasive ventilation still improves survival overall for people who are on it after adjusting for those other factors. And it also, in measuring lung function, appeared to slow the decline in lung function after people commenced ventilation. This is then breaking it down into people with different types of onset. And perhaps we think of strong interest is that in those people with bulbar dysfunction in our cohort, they actually appear to derive good benefit, and perhaps even better benefit than some of the other groups. Perhaps an easy number to look at is this one, which is the hazard ratio, which is really the reduction or in risk of death as a result of being on ventilation. So in bulbar onset, if you like, a 40% reduction compared to some of the other onset in lumbar or flail limb, where it was about a 30% reduction in risk. So this was really a bit against what the Burke study had originally shown. So I guess we had to think about why that might be the case. So I mentioned we spend a lot of time trying to make sure that the ventilation is well coordinated for people. And this is a shorter snapshot overnight of about 2 or 3 minutes, 2 minutes, looking at what's happening with oxygen level up the top, so staying excellent at 99%. This is the ventilator chugging away, so each wave here is a breath in. And then this is movement of the chest wall down here. So you can see that the chest wall and the ventilator are very well coordinated and moving well together. Now let me show you something different. So this is a time when that's not occurring. You're seeing oxygen level up here is good, 98, but falling down at about 86, which is moderately reduced. This is the ventilator chugging away here, pumping out breaths. But down the bottom, you can see there's just no movement of the chest and the abdominal wall for this prolonged period of time. It's about 40 seconds. And then it starts to coordinate again, and then it goes off again. So one of the common things that can occur is some collapse in the upper airway, but there can be other reasons for poor coordination with the ventilator. This is a publication from last year from a group that looked at where ventilation was not being effective. And they found about 40% of their group where the ventilation was not working that well overnight. And in more than half of those, it was due to these episodes of obstruction with collapse in the top part of the airway. And they went through a range of measures, and we do the same at trying to correct this, and they were able to correct it in about half. But interestingly, where they did that it also was related to better survival. So going to paying attention to detail, trying to improve at a fine detail level how the ventilator functions and works with people seems to improve survival. That includes things like managing secretions, looking at mask options. So in the Burke study, a lot of people use just a mouthpiece during the day, but if you have bulbar difficulty, using a full mask can be better, and we actually have things like adjusted straps so that people can easily remove that if they need to. And then making adjustments to the ventilator settings to try and overcome these episodes of obstruction. One of our other PhD students who's just finished, Leon Hannon, ran a study looking at the benefits of making all of those adjustments and showed that you could reduce these events overnight, and that also meant that people were able to use the ventilation more effectively and for more prolonged periods during the night time. I was going to move on and just talk briefly about a couple of other areas. So this is work that Nicole wrote up and published a couple of years ago, but the work actually dates back a bit longer. And when we first set up our service, and in fact internationally, many people brought patients into hospital, and they spent a number of days in hospital getting set up on ventilation, fiddling around with settings, doing training of carers and patients who are using it. But as most people will know, it's got harder and harder to get people into hospitals. They've become very busy places. And we got to a stage where people were waiting about a month to get into hospital to come and get set up on ventilation. And we changed our model of care to what we called a day model, where people came in for half a day, just for a few hours, working carefully with our team and the physiotherapists to set up the ventilation, and then take the equipment home. And we'd bring them back a couple of weeks later and do our fine-tuning that I've talked about. And so that dramatically reduced the waiting time for people to come in, and if we wanted it urgently, it could be done the next day. But interestingly, that also improves survival. And the point, there's some other papers showing similar benefits. Essentially, the takeaway point from this, if you reach the stage when somebody thinks that ventilation might be beneficial for you and you want to use it, it's better to get onto it and do it pretty quickly. Both to keep you well, probably improve survival, and of course to improve symptoms quickly. So what are the benefits then out of this therapy? So we think it improves quality of life and survival to some degree. We actually think that you can offer it to people who have impaired bulbar function, but there's additional things that you need to do to try and make it acceptable and easier for someone to use if they have bulbar impairment, and you have to fine-tune the settings carefully. And it is important, as I mentioned, to initiate it quickly once you make that decision. A couple of other things I thought were worth considering, and much of this is not in science, so this comes down more to the clinical level of what do we see on a day-to-day level. And it's important when you're having discussions with people that you consider their own reasons for starting this sort of treatment. It's at less than half people in Victoria that decide to use non-invasive ventilation, and that's fine. The goals might be to improve symptoms, improve their breathing, their sleep quality, improve sleepiness during the day. For some people, they may be wanting to try and improve survival, but it's important to work that out. And those goals may change over time. I was chatting this morning with people around their personal experiences of becoming dependent on ventilation and caring for somebody who becomes dependent on ventilation at home. It becomes very hard for them to come into a clinic. They have a high level of physical disability, and when that's connected to needing a ventilator, imagine getting the person into a car, getting the ventilator next to them, they've got to have a battery functioning, keeping a look on them while you're driving into clinic, not easy. And so how do we maintain contact with people, review their plan and their goals to make sure that what we're doing fits with what they want to do as time goes on? And we've certainly experienced, unfortunately, people who have found that hard to have that review and have ended up a bit trapped at home. So we've been working more with using telehealth programs, for example, and with certainly palliative care services to try and make sure that we maintain contact and adjust those goals as time goes on. We do a lot of work with our medical team. As I mentioned, we have an outreach nursing team, and it's important to have the right equipment, but it's also important to support the people at home. They need good support in terms of training for themselves about how to use the equipment, be able to contact someone if they have problems to troubleshoot those problems, and know what to do if something happens that's out of the ordinary. Do they need to go into hospital? Have they got someone else that they can contact to support them? Finally, I'd just like to thank our group. This is a not too old photo of our group, clinical and research. So I point out a few people. There's Nicole, who's sitting in row 3 there, who's nearly finished her PhD. David Derlowitz, who many of you will know, who's certainly been a key leader of our research program. Liam Hannon, I mentioned, who's just finished his PhD. And certainly Calvary Healthcare, Bethlehem in Victoria, who we work with very closely, and our research support through the Motor Neurone Disease Research Institute of Australia, specifically a recent grant from Jenny Simcoe that supported some of the work that I presented today, and the Mavius Gallienne grant that supports Nicole's work. Thank you very much. You're right, and people get used to it, so sometimes you don't realise what you're missing out on. And so if you have poor sleep, it can present in a range of ways. So the extreme end, that's becoming sleepy, falling asleep during the day, but it affects mood. You can become tired and grumpy, literally. So you might be snappy at the people around you, at your cats or the kids. Your brain may not function as well, so your cognitive function can go off and your concentration and memory may not be as good. So certainly those can be features of impaired sleep quality, and also elevation in carbon dioxide level, and can be a trigger to look at the breathing side and seeing if breathing support may help.
Thank you very much.